And now, to move forward to see if the new technology that is applied to carotid artery stenting will make the surgeons happy, I'm inviting Chris Kwolek, who is a surgeon, who's going to present his cervical flow reversal technique, the safest endovascular carotid solution. Chris.
Thank you, Claudio. And again, I'd like to compliment yourself and the other organizers, Mark and John, for this morning's session. This is a great example of why hearing speakers from different areas, whether it's neurointerventional, neurosurgery, cardiac surgery, interventional radiology, cardiology, vascular, we can really learn from one another. And this is another perfect example, sort of a hybrid approach to intervening or looking at treating vascular disease. So my assigned topic is cervical flow reversal, the safest endovascular carotid solution. I think the short answer is in the right hands, in the right training, with the right devices, it has the potential to be. And I'll give you that the reason for the caveat in a moment. These are my disclosures. Along with my strong personal biases, as Dr. Veith so aptly pointed out. These are all related to ongoing clinical research in the area of carotid intervention. And for this audience, I don't need to belabor the fact that we're talking about, at this point, extracranial carotid disease, the idea being we're trying to prevent stroke in that maybe 20% of the patients who have stroke related to large vessel atherosclerosis. And as you're aware, that's not only related to flow-reducing stenosis, but also the incidence of microembolic phenomenon. And as was very nicely pointed out in some of the other earlier interventional talks, whenever we're treating pathology, whether it's in the arch, in the carotids, or even intracranially, we need to worry about the risk of distal embolization. Here's actually sort of a recent overview, although by our administrative databases, it's only up to 2008, showing trends in carotid intervention in the United States over the last decade or so. And as you can see, there's been a slight overall decrease in the incidence of carotid intervention. CEA still remains the mainstay of therapy in about 85% of cases, and another 15%, 20% maybe going towards CAS. But CAS certainly has not replaced, for the moment, carotid endarterectomy in terms of being the mainstay of therapy. As we saw Dr. Brott present earlier, I think there are some important take-home messages. For the first time in a prospective trial, we did achieve outstanding intervention related complication rates, both for CEA across multiple centers and multiple operators, and for CES, and I think that is important to remember. And I do think there are some differences, as we've heard many of the different presenters talk about. You can spin the data many different ways. I do think we as surgical interventionalists need to acknowledge that there is a higher myocardial infarction event rate, there is a higher incidence of cranial nerve injury with open intervention, and there can be a higher incidence of wound complications. However, as Dr. Veith very succinctly pointed out, the peri-procedural stroke risk is significantly higher in CAS in this group. And when we talk about the older population, greater than 75, we see that event rate goes even higher, and as was pointed out, with the symptomatic patients. So is there a solution to this? And in fact, when we look at the incidence of stroke in CREST, the vast majority of those occurred at the time of the intervention or shortly thereafter, day zero. So what are some of the things that we could do to decrease this? Part of this may be related to embolic phenomenon or process as we're trying to get catheter sheaths in place, as we're passing distal embolic filters or protection into the intracranial circulation or into the just below the siphon. Part of it also may be post-intervention with embolization through the interstices of our stents. And I know that Dr. Schoenholz will talk to us about that and a potential solution in the next presentation. But I also think it's important to note that after that intervention period is completed, when you get out to 3 months, 6 months, 4 years, the incidence of restenosis is low, and the incidence of subsequent neurologic events is similar between the groups. So if we can get over that acute problem, I think that may be a potential solution. As was mentioned earlier by Dr. Veith, I think we also need to pay attention to what's going on in the brain. We saw some very elegant discussions discussing salvage techniques for intracranial stroke and thrombus and preventing embolization. And in this sort of series of studies looking at the incidence of new diffusion-weighted MR lesions in the brain after intervention, we know that with transfemoral casts using a variety of different filters, the incidence of new lesions, and we still don't know what these signify. We don't even know the best way to quantify. Is it total number of lesions? Is it total volume? But nevertheless, with the concept that more has to be worse than less, we know that distal embolic protection is not particularly effective at preventing new diffusion-weighted MR lesions. Even with the current proximal occlusion devices, such as the MoMA device, which is now owned by Medtronic, or the Carotid device, which is now owned by W.L. Gore, there still is a cost with getting that device into place. What we also know is through the ICSS trial, even with carotid endarterectomy and our no-touch technique, there's a small but definite incidence of distal embolization as we apply clamps. So the question is, if that has truly become our gold standard, can we get a carotid intervention system to be able to match that? We also know that silent infarction happens, and over time we've seen several longitudinal studies, including this study from the Framingham study, looking at the incidence of new either neuropsychological testing decrease and or new episodes of stroke and problems followed in a long-term patient population who's being seen as part of the Framingham study. And in these patients, there were close to 2,000 patients. Carotid duplex was done, MR and neuropsych testing done over time. And Dr. Romero and his colleagues found that both internal carotid, intimal medial thickening, but not common carotid disease, was associated with increased incidence of silent cerebral infarcts, lower total brain volume, and, as was talked about earlier, poorer performance in verbal and nonverbal memory measures. So one of the things we have to be concerned about is not just the risk of acute stroke, but what about long-term neuropsychologic functioning or cognitive testing? And as you saw earlier, Dr. Broughton, his colleague Dr. Lull, the co-PIs, are including some aspects of long-term neuropsych testing as part of the CREST-2 trial. Just as importantly, an internal carotid stenosis greater than 50% was associated with an increased incidence of silent cerebral infarcts, large white matter hyperintensity, and poor performance on executive function. So again, we haven't proven it from a causality standpoint, but nevertheless, there's a lot of smoking guns pointing to the fact that carotid disease and these microembolic lesions may lead to poor long-term cognitive functioning. And certainly the concept of cerebral reserve and how much you can tolerate is an important one. This is again from a publication by Dr. Lull, one of the co-PIs for CREST-2, again commenting on this incidence of silent cerebral injury after CAS. We saw very similar numbers come out of that ICSS study. So what we've learned is that there are certain CAS lesions that are high risk. Symptomatic lesions, as was pointed out earlier, elderly patients perhaps with either increased arch disease or tortuosity or decreased cerebral reserve. We're trying to get a handle on differences in plaque morphology, vulnerable plaque or plaque that's more likely to embolize. We also know that just anatomy, tortuosity, calcification in the arch can increase the risk. In those patients with critical stenoses that we have to pre-dilate without protection in place, we know that that's high risk. And the longer complicated patients with complex lesions or even previous radiation. So perhaps the most important thing that's come out of this is there was a major wake-up call. And I credit Dr. Veith and many of our colleagues out there for raising this alarm and saying, well, wait a second, we don't just need more stenting. What we need is better patient selection, learning who not to stent, along with improving our technique and hopefully our technology. So Dr. Perotti and Dr. Schoenholtz very early on said, what if we could try to reproduce what we do with carotid endarterectomy with an endovascular approach? What if we could apply a clamp to the common carotid artery endovascularly, and at the same time, and as seen here, place a balloon in the external carotid to prevent that reversal of flow and siphoning back up into the internal carotid, and actively aspirate back while we were performing the intervention? Could we decrease the risk of that microembolization and our major neurologic events? And in fact, in this result from the prospective Gore trial, this is one of the very first trials ever to show that there was no increased risk in octogenarians when we were performing carotid angioplasty and stenting. And I also bring to your attention the fact that in the combined MAE group, there was no difference between symptomatic and asymptomatic patients. I think this is critically important. And in fact, the same results can be achieved with similar devices. I'll show you the MoMA trial in one moment. But I think the concept of proximal protection does make sense, and it appeals to us with a surgical mindset and an interventional mindset. It allows you to protect against embolization before crossing the lesion with any wire or filter or balloon. You can choose which wire you want to use. You don't have to have a distal landing zone in those patients with a tortuous distal internal carotid artery, and you're less limited by some of the anatomy and types. And hopefully it's very efficient in terms of trapping or removing debris. These are the results from the ARMOR trial, again, with that MoMA device before it was purchased by Medtronic. But again, I bring to your attention on the bottom set of bars, the symptomatic patients had actually a lower event rate than the asymptomatics. And once again, symptomatics in patients greater than the age of 75 were no different than those greater than 75. A very, very important finding. And in fact, this data alone has changed my paradigm in terms of treating symptomatic patients with carotid angioplasty and stenting. If I cannot perform an open operation and are considering endovascular intervention, I will only do that if I have access to some type of proximal occlusion and or flow reversal. So again, what if we could obviate some of the problems with the arch access, with getting through tortuosity, getting through disease? What if we could use direct carotid access? What if we could isolate the bifurcation before treating the lesion, clamping or controlling the common carotid as we do with open endarterectomy, and then backbleeding or aspirating to wash out this debris? Well, this is not a new concept, and this is from an article published in the Annals of Vascular Surgery in 2004. I apologize for the font, but Enrique Criado at Michigan currently was one of the founders initially of this approach. Actually, Dr. Veith, again, had something to do with this, as one of his former fellows was very actively involved in this, Dr. Chang. And you can see there were numerous publications, small single-center series with very, very good major and minor stroke rates and very reasonable short-term results. But because of the excitement of this, industry basically became involved and said, well, what if we could commercialize this concept? What if we could take a large bore catheter, have direct access to the common carotid, avoid the arch, isolate the bifurcation, and have a flow reversal system that allowed us to not lose any blood, but in fact return it to the venous system. And so the Silk Road Medical Company was formed, the Michi Neuroprotection System again, and my disclosure is myself and my partner, Dr. Rich Cambria, serve as the national co-principal investigators for this FDA-approved trial currently. Well, their first-in-man results, as in many series, was outside the U.S. Doctors Kolvenbach and Pinter in Germany. They had no events in their primary endpoint. Again, a very outstanding result in terms of major stroke and MI. But just as importantly, I think, they did a diffusion-weighted MR sub-study in 55 patients and found that their event rate of new diffusion-weighted MR lesions was identical to that seen in the open carotid endarterectomy group for ICSS. And I think that's going to be the gold standard going forward. It just won't be major stroke or minor stroke or stroke and death. I think it will also be the incidence of new microembolic lesions to the brain. So Silk Road has a clinical plan in terms of what they're doing for trials. The proof trial, as you saw, there are several single center registry with Samira McDonald, who's now over here in the U.S. There was a Tesla EU post-market registry, and the Roadster U.S. pivotal trial, as I mentioned earlier. There are up to about 20 U.S. sites. We're about halfway through the enrollment currently, and this is for both symptomatic and asymptomatic high surgical risk patients. There is no age limit, and we're allowed to use any of the currently FDA-approved carotid stent devices. I just show you one case as an example. There are very specific parameters, though, for inclusion in this. We need to have a focal lesion in the internal carotid. We also need to assure ourselves that the common carotid access is relatively disease-free. Not a lot of calcium, Tortuosity we can talk about in a moment. And in fact, for my purposes, I almost always obtain a CT angiogram to look at the arch anatomy, the neck anatomy, and intracranial anatomy as a standard before carotid intervention. This is one example where we place this sheath after micropuncture access directly into the common carotid. We're able to obtain an angiogram both in an antegrade and retrograde fashion. We're able to transiently occlude flow, and this device is large enough that we can achieve flow reversal without the external carotid occlusion balloon, as in Dr. Parodi's system. And I think this is a distinct advantage. There's enough reversal of flow that we're actively sumping from the brain, and it begs the question, should it be used in conjunction with perhaps some of our neurostroke colleague interventions to try to sump out or remove distal intracerebral clot for acute stroke treatment? I think that's a fascinating question. So here's a critical stenosis, as you can see, a patient with previous radiation and treatment. We're able to cross with a wire. I don't pre-dilate anymore. I go straight to a stent if I can cross, and then post-dilate with active aspiration. And as you can see, markedly improved flow. The standard pre and post intracranial views to assure that we don't have distal embolization. And then just as importantly, afterwards, we're able to visualize not only the stent, but as you can appreciate the closure there for the common carotid access site. There are tips and tricks related to this. We have had some dissections related to aggressive use of a Rommel tourniquet, and I think there are some techniques to be gleaned from that. But this is an example of the type of debris that can be achieved with the flow reversal in the filter system. So I think in summary, at this point, carotid revascularization using this proximal occlusion neuroprotection system has been shown to be safe and feasible through this proof trial. It had a very low rate of myocardial and cranial nerve injury. And we also know that I think there's a significant chance for improvement in terms of distal microembolization. I do think new diffusion-weighted MR lesions are going to be a very important endpoint as well. And in fact, our larger multi-center experience is currently ongoing. We're also in the process of putting together a prospective multi-center study to specifically compare diffusion-weighted MR across sites, both for CEA and CAS, hopefully both transcervical and transfemoral. So to date, and I apologize, this is a bit out of date, at this point the combined European trial data was about 205 patients with an overall composite stroke and death of about 1.5%. We are now well over 100 patients in the pivotal trial, although we do allow up to 5 roll-ins per investigator, so the trial will run a little bit longer. The other added benefit is I have now progressed from doing this under general anesthesia with a little bit of caution and trepidation to doing all of these under local anesthetic. Our total procedure time is about an hour, with my cross-clamp flow reversal time averaging between 5 and 6 minutes. So I really do think this has the large potential to improve our results. I really don't think CEA is going to progress much. I think we're getting better at patient selection and some minor improvements in peri-procedural care. But I do think CAS has a long way to go, and with things such as the hybrid flow reversal system and perhaps the covered stent that we're about to hear about, I do think we have significant room for improvement in CAS. So along with a significant learning curve for CAS, this is something that every single one of you in the room is capable of adopting very quickly, and with some minor modifications in terms of how you access the common carotid just above the clavicle is something that I think would be very, very widely applicable across a broad spectrum of operators. But I certainly think we need further evaluation, and as was mentioned before, we need to study these both inside prospective trials and as part of registries as it's extrapolated out into the general community. Thank you for your attention.